This is the first of 4 lectures that I'm going to be giving, and I'm focusing in this lecture on certainly two pathogenic diseases that affect monochorionic twins in pregnancy. And as you know, twins overall contribute to very high rates of preterm birth, and as a consequence of that and other specific pathologies have increased risk of both perinatal mortality and morbidity. So I'll focus on these 2 pathologies today. As a background, multiple pregnancies complicate approximately 1 in 60 pregnancies, and the majority of these, over 95%, are twin pregnancies. Twins are divided, as you know, into monochorionic twins, which complicate 20% of twin pregnancies, and dichorionic twins, 80% of twin pregnancies. And certainly, variably around the world, the prevalence and incidence of twinning and higher order multiple births has increased due to both to subfertility, use of subfertility treatment, to the deferring of reproductive activity, in other words, mothers putting off a pregnancy until a higher maternal age, which increases twinning, and changes in race and ethnicity throughout the world. Different groups have different rates of twinning, and these overall seem to have increased twinning rates around the world. You'll know that the pathogenic, underlying pathogenicity of twin pregnancies is related to both zygosity and chorionicity. About 70 to 75% of dichorionic twins are dizygotic. 75% of those are due to fertilization of 2 separate eggs, and about a third are associated with the separation of a blastocyst to form a dichorionic twin pregnancy early on. But the real pathogenic nature of twin pregnancies is focused upon the late division of the fertilization of a single blastocyst, leading to monochorionicity, and the later that division occurs, the greater the risk for the pregnancy in terms of fetal perinatal mortality and morbidity. The top right-hand side of this slide shows data from the UK Embrace population denominator data for perinatal mortality. And you can see from this prospective data set, the stillbirth and perinatal mortality rate has gradually decreased year on year in the UK from 2000 onwards. And that's due to a systematic teaching approach with clear guidelines that have led to a sustained reduction in perinatal mortality. We know, though, that with the exception of preterm birth, both spontaneous and iatrogenic, it is monochorionic twinning that leads to the highest risks of morbidity and mortality in twins. The now classic data from Kypros Nicolaides on the left-hand side of this slide shows the cumulative fetal loss week by week throughout pregnancy for both monochorionic and dichorionic twin pregnancies. And you can see that the risk for monochorionic twins is 5 times that of dichorionic twins. And that risk is greatest between the gestations of 14 and 26 weeks gestation. And again, from the Embrace data, you'll see from our published work that the stillbirth rate in monochorionic twins was 4 times that of dichorionic twins, and dichorionic twins have very similar perinatal mortality to singletons. Twins, though, carry complications that are increased, common pregnancy complications that are increased over singleton pregnancies, that of miscarriage, perinatal death, stillbirth, growth restriction, preterm birth, and major congenital abnormalities. And you can see that there is a systematic rise in prevalence from singletons to dichorionic twins, with the highest risks being in monochorionic twins. And in monochorionic twins, these risks are associated with placental vascular anastomoses. There being three kinds: arterial venous, which are usually unidirectional flow, venous venous, and arterial arterial, all of which are associated with bilateral flow between the babies. And much of this work has been elucidated by placental injection studies performed in the postnatal period. So the two major complications, not exclusively, but the two common and major complications associated with placental vascular anastomoses in monochorionic twins is twin-to-twin transfusion syndrome and twin anemia polycythemia sequence. And these are associated with specific angio-architectural changes in the placenta, as well as differences in sharing of the placental territories. Key to this from a prospective management sense is the first trimester scan, which is performed commonly at between 11 and 14 weeks gestation and allows the diagnosis of a twin pregnancy, and with high sensitivity and specificity, the dating and the allocation of chronicity, which is the cornerstone of management in twin pregnancies. So this scan right at the beginning of the pregnancy is very important in terms of allocating risk and therefore a care pathway going forward. So twin-to-twin transfusion syndrome complicates 10 to 15% of monochorionic diamniotic twins, and if untreated, is associated with at least 70% of the total perinatal mortality associated with monochorionic twins. And it's associated basically with amniotic fetal discordance and changes within the presence, the way the twins look on ultrasound scan going forward. You can see that the amniotic fluid discordance is high, around, largest with polyhydramnios around the recipient twin, and in the donor twin there is reduced liquor around the baby, with the baby often being stuck to the side wall of the uterus, and women often present with uterine activity, severe discomfort, and sometimes breathlessness. From the first trimester onwards, about 30% of monochorionic twins start to show differences in amniotic fluid volume, which is the key diagnostic criteria for twin-to-twin transfusion syndrome. But of these, only half of that 30%, i.e. 15%, will go on to have overt twin-to-twin transfusion syndrome. Assessment of the fetal cardiovascular response in twin-to-twin transfusion syndrome is very important by measuring umbilical artery Doppler velocimetry in both twins, but also and especially in the recipient twin, looking for changes in preload and afterload in the heart by measuring ductus venosus velocimetry. And the recipient twin has an increase, progressive increase in blood pressure and vascular resistance due to hypervolemia, and releases vasoactive mediators into the circulation, leading to cardiovascular strain in the recipient and a potentially reversible cardiomyopathy. Whereas the donor twin experiences decreases in blood pressure and increased placental resistance that causes impaired renal perfusion and oligohydramnios. So on the left-hand side of this slide is the care pathway for monochorionic twins, set out to detect twin-to-twin transfusion syndrome and other common pathologies in monochorionic twins. That involves, from the first trimester onwards, scans at 2-weekly intervals from 16 weeks gestation, measuring the Doppler velocimetries and the Lycor volumes, as well as fetal biometry. And that interval of 2 weeks has relatively shaky evidence base, but at least one study indicates that if you perform scans at a median of 2 to 3 weeks, you identify the majority of babies with pathology in a timely way, as shown on the right-hand side of this slide. Indeed, data from Leuven, from Tim van Meegen and Jan de Press, indicated in a prospective study and then using a prediction algorithm that it was amniotic fluid deepest vertical pore difference between the amniotic sacs of the two twins that actually is most sensitive and specific for predicting the diagnosis of twin-to-twin transfusion syndrome. And a deepest vertical pore difference of greater than 3.1 centimeters is associated with a high diagnosis. You see 85, nearly 90% of babies will go on to develop twin-to-twin transfusion syndrome. So using serial ultrasound scans in even apparently normal monochronic twins is very important to detect these pathologies. The diagnosis of twin-to-twin transfusion syndrome is made when in the recipient's amniotic fluid sac, the deepest vertical pore is greater than 8 centimeters before 20 weeks or greater than 10 centimeters after 20 weeks, with a corresponding oligohydramnios, a reduced lichal volume, in the donor twin of less than 2 centimeters. And that is the key diagnostic criteria for twin-to-twin transfusion syndrome. Not about Dopplers, not about any sophisticated measurements, but the measurement of differences in amniotic fluid volume. Of course, once the diagnosis is made and there is a difference in amniotic fluid volume, then one goes on to look at the severity of the twin-to-twin transfusion syndrome, which can be linked to outcome. And Ruben Quintero from Florida, at the time when he devised this staging system, indicated that by using the Doppler velocimetry and also visualizing the fetal bladder, you can stage twin-to-twin transfusion syndrome, stage 1, where both babies are visible, have visible bladders, but there is discordant lichal volume. Stage 2, where in the donor fetus, the bladder is not absent because of oligouria. Stage 3, where there is abnormal Doppler velocimetry, either in the donor or the recipient fetus. And stage 4, where there is already cardiac failure in the recipient fetus with the presence of hydrops fetalis. So that staging system is used universally around the world to give a prognostic information as to the severity of twin-to-twin transfusion syndrome. And the treatment of twin-to-twin transfusion syndrome has been revolutionized by the use of fetoscopic laser ablation of the placental vasculature. Under local anesthetic, after scanning, doing a detailed scan of the baby, putting a fetoscope, which is only 5 to 6 millimeters in diameter, into the recipient sac and visualizing the anastomoses that cause this problem on the surface of the placenta, and passing a laser fiber down and lasering the blood vessels as they cross the intertwin membrane. When you use this technique, which I wrote a Cochrane review back in 2014 indicating the evidence that demonstrating that this is the best treatment for this condition. When you use this treatment, then you can expect to get outcomes very similar to as demonstrated in the histogram at the top of this slide. So last year in our centre, we did nearly 50 fetoscopic laser ablations, and you can see that in 91% of pregnancies, there was at least one survivor. And in 52 to 60%, there was 2 survivors. In 40%, there was 1 survivor, and under 10%, sadly, both babies died. And when you compare that to the natural history of twin-to-twin transfusion syndrome, where over 95% of babies, both babies will die, that's a massive change in the outcome for the pregnancy. But there are problems. One is the risk of prematurity, as I mentioned, but also the risk of cerebral morbidity in surviving twins. And this review by the group in Leiden in Holland demonstrate that the cerebral morbidity overall is 8.6% post-fetoscopic laser ablation, but that in uncomplicated monochlorate twins, the risk is about 6%. So the excess risk is about 2%. But over half of these are due to prenatal contributions. And the things that predispose the fetus to these risks are a recurrence of twin-to-twin transfusion syndrome after treatment, twin anemia polycythemia sequence, which I'm going to talk about in a minute, single intrauterine twin demise, premature delivery. A multivariate analysis shows that it is prematurity, which is unifying for all of these complications, that leads to the greatest risk. We looked in a retrospective study at the use of MRI in terms of identifying cerebral morbidity in babies treated with twin-to-twin transfusion syndrome in a cohort of about 73 fetuses, half of where there had been one single intrauterine demise, and using a high-resolution, high-speed MRI to investigate the fetus on average a month after the treatment or single twin demise. And overall, we found cerebral morbidity on MRI present in nearly 10% of babies. When you look at these in the cases that had fetoscopic laser ablation, then there were 3 cases out of 32 that had cerebral morbidity. And many of these were not diagnosed on ultrasound, but only diagnosed on the MRI, as you can see on this slide here. When we looked at those 3 cases in more detail, there was one case that had mild ventricular megaly, which was thought to be due to intraventricular hemorrhage, which seemed to resolve in utero, and the baby was followed up and had no sequelae. But in 2 babies, 6.3% of the total, there was evidence of cerebral infarction, and both that led to pathologies of unilateral cortical reduction and also focal infarction of the cortex involving white and grey matter abnormalities with reparative polymicrogyria. So sometimes significant brain morbidities. And identifying those, certainly in the UK, then allows a discussion with parents to warn them of handicap, and in some cases, the option of termination of pregnancy. The other pathology that I'm going to talk about today is twin anemia polycythemia sequence. And this is a vignette provided actually by my wife in her practice, where she was following a 40-year-old midwife who had had 6 attempts at IVF and failed, and then she was pregnant with monoclonal twins. The recommendations at the UK at the time were not to screen for twin anemia polycythemia sequence, but she requested, because she was anxious, serial measurements of middle cerebral artery peak systolic velocity, screening for anemia and polycythemia. And you can see the separation between the 2 fetuses of middle cerebral artery peak systolic velocity being diagnostic of twin anemia polycythemia sequence and leading to transfusion of the twin and then preterm delivery. Twin anemia polycythemia sequence TAPS can occur in apparently uncomplicated twin pregnancies. It's where there is anemia in one twin and polycythemia in the other twin. And this is not twin-to-twin transfusion syndrome. If you measure the cord hemoglobin concentrations in twin-to-twin transfusion syndrome, the babies are not anemic and polycythemic. There is no discordance, but in this pathology there is. It can occur more commonly in complex monoclonate twins with selective growth restriction, for instance, post-fetoscopic laser ablation in nearly 15% of cases, but spontaneously in uncomplicated monoclonate twins in 3%. And although it can occur at any gestation, it occurs with a median height at nearly 24 weeks of gestation. And there are varying recommendations for screening for this around the world. It's due to the presence of vascular anastomoses, but these anastomoses are hair-like connections at the periphery, the peripheral edge of the placenta, that cause a very slow leak of blood from one fetus to the other. So the anastomoses are less than 1 millimeter. in size. And as I've indicated, the screening for this involves middle cerebral artery peak systolic velocity, just as you would use to investigate a hydropic fetus or in babies with potential rhesus disease, demonstrating in the anemic fetus an elevated peak systolic velocity, and in the polycythemic sequence, a reduced peak systolic velocity, and that difference is shown here on this graph here, a difference in the discordance in middle cerebral artery peak systolic velocity. But also looking for changes in cardiac dysfunction, including a pericardial effusion, a starry sky liver pattern within the fetal liver of the polycythemic fetus, and also a difference in echogenicity in the placenta between the placental territories between the anemic and the polycythemic fetus. This is the prenatal and the postnatal staging for TAPS. And you can see that over the years we have moved from an individual measurement giving a threshold for polycythemia and anemia to looking at a difference in middle cerebral artery peak systolic velocity, with the threshold for diagnosis being a difference of greater than 0.5 multiples of the median between the two twins' middle cerebral artery peak systolic velocity. And this corresponds to, as you can see in the postnatal period, if untreated, a discordance in fetal hemoglobin, with stage 1 having a discordance in fetal hemoglobin of greater than 8 grams down to quite severe changes and anemic and polycythemic features in the fetus, and also changes in reticulocyte count in the donor fetus. There are complications to untreated TAPS. The anemia, the anemic fetus with the donor has high risk of chronic hypoxia and fetal demise, similar to the polycythemic fetus, which has increased risks of ischemic assault, but also complications due to poor peripheral ischemia. When you look at perinatal mortality, 22% have fetal deaths associated with the donor, which is more common than in the recipient in 7%. And the risk factors for perinatal mortality involve being a donor and also the severity of the disease itself. The donor twin has a 4-fold increased odds of neurodevelopmental disorders if it survives, and in particular that's associated with cognitive delay, and also noted in the last 5 years from work done in Leiden, high rates of neurosensory deafness in the donor, which may go undetected unless screened for. You can also see that there are associated peripheral vascular changes that can occur, causing peripheral ischemia in the limbs, even in appropriately treated babies. The treatments for TAPS involve conservative management. In other words, just watching and waiting. And that's usually when the gestational age is relatively advanced. Before 26 weeks of gestation, and fetoscopic laser ablation is the treatment to ablate those vascular hairline anastomoses, but also by treating twin-to-twin transfusion syndrome by using the Solomon technique, where you laser right the way across the placenta, ablating all vascular vessels. And then between 26 and 30 weeks of gestation, as a prelude to delivery, intrauterine transfusion can be used to treat the anemic fetus just prior to delivery. And obviously, if the diagnosis is made after 30 weeks of gestation, then delivery can ensue. And a recommendation from the national guidelines in the UK indicate that in complicated monochoric twins, you consider delivery, elective delivery, between 32 and 36 weeks gestation. So those are the two pathologies that I've outlined quite quickly, going through them today. I want to draw your attention to the Royal College of Obstetricians and Gynecologists Green Top Guideline, which was reviewed and updated by myself and Leanne Bricker and published in the in British Journal of O&G this year. It outlines the modern management of monochorionic twins and links it to NICE guidelines and other international guidelines. And this gives a comprehensive view. If you're able to look at it online and after this talk go through it, you'll see that it goes through systematically how monochorionic twins and links to all twins should be managed during pregnancy prospectively to reduce long-term risks of morbidity and mortality. So thank you for your attention, and I look forward to speaking later and having any questions.
Mark, thank you so much for sharing all this data with us. It's always difficult to distinguish TTTS and TAPS. I am always confused.
Yes. I mean, twin transfusion syndrome is a chronic problem, and there is not a difference in hemoglobin between the twins, and its diagnosis is made really it's not a difficult diagnosis to make on scan. People make it quite difficult because they try to do all sophisticated things, but actually the diagnosis is the difference in Lycol volumes, of deepest vertical pool Lycol volumes between the twins. TAPS is a much more insidious disease process that's less common, but it still can be very pathologic, as I have outlined.
It's worse.
And indeed can be worse.
Any questions? Comments? Please, Orhan.
Go ahead.
No one has questions?
You have one.
Okay, I can have one. Mark, it was absolutely wonderful presentation. I learned a lot as a poor pediatric cardiologist. Two questions. One of them is, what is the rationale to use steroid and magnesium sulfate? It tends to be quite common recently as magical drug coming back from 1990s and nowadays it's more commonly used. That's one question. And the second one is, it all of a sudden stopped those babies being referred to us with twin-to-twin transfusion. I saw in your presentation that cardiac dysfunction is not predictable outcome. Is that the reason, or do you have other reason why cardiologists don't get it anymore? I'm not complaining, I'm happy about it. Reduction of workload. Thank you.
Okay, thank you. So to answer your first question about the role of steroids and magnesium sulfate, I think in singletons and in twins overall, there is no doubt that using prenatal steroids, usually beclomethasone, given intramuscularly to the mother, 24 to 48 hours before delivery, reduces perinatal mortality and morbidity. So when you're considering delivery of the fetus, using that with magnesium sulfate if the delivery is before 32 weeks of gestation is very valid because it reduces the risks of dying overall for the fetus. The problem and the controversy about it is that you should only really give the steroids and the magnesium sulfate if you are sure that the woman is going to deliver. And giving them prophylactically can lead to multiple doses of steroids or magnesium sulfate. And there is concern in singletons and in twins that by giving steroids in multiple doses, that may have an effect long-term on the cognitive outcome of the fetus. But I think, overall, we're dealing with a highly morbid situation where one or two babies may not survive, and if they do survive, there are risks of handicap. So in those situations, once you feel that you are reaching the stage when the pregnancy should end, steroid and magnesium sulfate should be given.
What does magnesium do?
What does
it do?
What the mechanism? Well, to be honest with you, no one really knows exactly why it is neuroprotective. In magnesium sulfate, it's thought to have a neuronal protective mechanism, but there is a whole raft of evidence from animal models by Montliggins in New Zealand back in the 1970s, right the way through to big prospective studies demonstrating the beneficial effects of steroids. But I don't think it has any specific effect directly on twin pregnancies. It's just a unifying thing for a premature baby. In terms of your second point, I think that it's a shame that people aren't referring you as a fetal cardiologist babies with twin-to-twin transfusion syndrome. And the reason I say that is that although I showed the slide that actually performing quite detailed fetal cardiological assessment of the babies in monochromatic twins before twin-to-twin transfusion syndrome doesn't predict whether they would develop it. Once they have it, then there is quite good evidence that both the myocardial performance index is abnormal in the recipient fetus, and also at the extremes you get tricuspid regurgitation. Now, for the most part, those are important things to know about, but once you treat the fetus by fetoscopic laser ablation, then they go away. So that's why I said they're reversible cardiac function. But in about 5% of treated babies, where the babies survive, you can get progressive abnormalities of the fetal heart, right-sided abnormalities, so often pulmonary stenosis and right-sided cardiac dysfunction. And in those situations, it's very important, I think, to have fetal cardiology assessment, both to consider treatment while the baby is still in the womb. Very unusual to offer balloon dilatation in these babies, but certainly supportive treatment. And also so that they, once the baby's born, people like yourselves can then scan the baby afterwards and give support to the baby going forward. So I think fetal cardiologists have a role, and certainly, although they may not be involved before treatment, unless there are signs of cardiac dysfunction, they have a role going forward to assess babies and to exclude the rare complications that can affect these babies when treated.
Excellent, thank you very much.
A question?
Thank you.
Greetings, Gensopa, OBGYN. So this question is coming as a generalist, specifically about the ultrasound finding in TAPS, the finding of differences of placental echogenicity. How strong does it correlate with TAPS, or how specific it is to it? And can we actually use it? I mean, probably should to refer for further studies for
I think yes. So I think middle cerebral artery peak systolic velocity, gating the middle cerebral artery and measuring that is very sensitive and specific for fetal anemia. It's a little bit less sensitive for polycythemia, but not much. And I think the difference in middle cerebral artery peak systolic velocity is very important in diagnosing TAPS because of the reason I've said. The threshold at which treatment is considered varies. So for instance, I indicated that a difference in greater than 0.5 multiples of the median is what now is taken as the diagnostic value for TAPS. And that was from Holland, from the Leiden group. But in the Green Top guideline that I was an author on, we actually said that you don't need to refer, unless you are concerned, to a tertiary centre until the difference is greater than 1 multiple of the median. So it's a much bigger difference. And the reason for that is because Elizabeth Louis from Leuven did a prospective study looking at all the cases of TAPS over a 15-year period, and found that of those that had a very mild change, over 80% of them got better without doing anything. So it's only when it was quite marked, when the difference is greater than 1 multiple of the median, that then it didn't go away and you need to consider treatment. So I do think it's important to screen for. I think it needs to be, these tests need to be performed on people by people that are used to doing it, and then consideration and have a consideration of how to treat the baby once a diagnosis has been made. Because otherwise, in the majority of these babies with TAPS, there is a risk of the complications that I've indicated. But it's not easy to manage it sometimes.
Thank you very much for Kilby.
Thank you.
You have a question also? Okay, because we're a little bit late.
Thank you for nice presentations.
Thank you.
Which stage of quick-tero do you prefer to do laser therapy, and which weeks? And according to you, quick-tero stage, it is enough for choosing therapy.
Yeah.
Thank you very much.
I think so. I think for all stages of twin-to-twin transfusion syndrome, need consideration for fetoscopic laser ablation. Certainly from stage 2 onwards, between 16 and 26 weeks of completed gestation, we consider managing with fetoscopic laser ablation. Stage 1 disease was more controversial, again, because there was a feeling that it may get better on its own. And I was part of a group that did a randomized controlled trial from Paris, looking at stage 1. But again, that showed that reduced the risks of complications in survivors of babies that were treated with twin-to-twin transfusion syndrome if you perform laser therapy in stage 1, but there were more fetal deaths. So stage 1, I think, is more controversial, and you have to tailor the management individually for the patient. But stage 2 onwards, then I think fetoscopic laser ablation is the way forward. If the pregnancy presents with late twin-twin transfusion syndrome, which is present in about 8% of pregnancies with twin-twin transfusion syndrome, so after 26 completed weeks, then you have the option of delivering, you have the option of waiting and watching, amnio drainage, or laser ablation. And there is some evidence that certainly towards 26, 27, 28 weeks, that laser ablation may have a role and prolong the pregnancy and reduce perinatal mortality from prematurity. But in that situation, most babies are going to be delivered by 32 weeks. So thank you for your question.
Okay, thank you very much, Professor Kilby.